Hi, I am Dr. Wafaey Badawy, a consultant histopathologist. I am going to talk about epithelial neoplasms of the ovary, high-grade serous carcinoma. Definition and general background. It is a malignant epithelial tumor with serous tubal-type phenotype and high-grade cytomorphology. It is the most common histologic subtype of surface epithelial ovarian carcinoma, 95%. It is bilateral in 60%. It is more common in Western Hemisphere. It is rare in first 2 decades, but a steady increase thereafter. Mean age 56 years. Most patients present with advanced stage, more than 95%, transabdominal spread to involve peritoneum with omental caking, abdominal lymph nodes. Lungs, liver, and pleura are common sites of distant metastasis. Clinical features: pelvic or abdominal enlargement, vague pain, urinary or gastrointestinal symptoms, ascites, elevated serum CA 125. High-grade serous carcinoma usually exhibits TP53 mutations and somatic or germline abnormalities of BRCA1 and or BRCA2 or related genes. Radiology description: serous cyst adenocarcinomas. They are unilocular or multilocular, often bilateral, cystic and solid ovarian masses. Papillary projections could be identifiable. This photo shows a contrast-enhanced pelvic CT scan showing bilateral ovarian masses, mainly solid on the left side and solid and cystic on the right, with lobulated contour and calcification. This photo shows a contrast-enhanced CT at the level of the common iliac arteries, revealing a large confluence of tissue masses separating the small bowel from the anterior abdominal wall, representing the omental cake. Gross appearance: high-grade serous carcinoma. This photo shows predominantly solid and focally necrotic tumors replacing both ovaries. High-grade serous carcinomas of the ovary. These two photos show exophytic large bulky tumors. They show an admixture of cystic, papillary, and solid growth. The solid foci show hemorrhage and necrosis. High-grade serous carcinomas of the ovary. This photo shows an ovary with a solid and cystic tumor. The cysts are partially lined by papillary proliferations. Necrotic foci are present. This photo shows an ovarian cyst having a smooth outer surface. The anterior wall contains two pedunculated cauliflower-like masses with stalks. Ovarian serous surface papillary carcinoma. It grows predominantly on the surface of the ovary. There is minimal or absent parenchymal invasion, as well as no intracystic growth. Microscopically, the tumor could have abundant cynomia bodies. Note the bright yellow corpus luteum in this photo. When the bulk of the tumor consists of extra-ovarian serous carcinoma with only focal less than 0.5 cm surface growth on the ovary, it is considered as primary peritoneal serous carcinoma with involvement of the ovaries. Fallopian tube carcinoma. This photo shows a friable grade tumor filling the lumen. Microscopic features. These tumors exhibit complex papillae, highly stratified cells, epithelial buds, and stromal invasion. A defining feature of this lesion is the presence of cells with diffusely high-grade malignant features. As illustrated here, these features include high nuclear to cytoplasmic ratio, that is, nucleomegaly, eosinophilic cherry macronucleoli, marked hyperchromatism, frequent mitosis equals or more than 12 mitotic figures per 10 high power fields with frequent abnormal mitotic figures, multinucleated tumor giant cells. High-grade serous carcinoma showing a focus of microinvasion of the ovary, invasion of ovarian stroma with desmoblastic stromal response. By definition, stromal invasion is present which separates them from serous borderline tumors. High-grade papillary serous carcinoma of the ovary showing invasion of underlying ovarian stroma with comedonecrosis, a large nest of highly pleomorphic tumor cells with comedonecrosis, cynomia bodies within a necrotic focus. Necrosis is frequent. Set pattern of high-grade serous carcinoma. S stands for solid pattern. E stands for endometrioid or pseudoendometrioid pattern. It is not evidence of a component of endometrioid carcinoma. T stands for transitional cell carcinoma-like pattern. Ovarian carcinomas which show said pattern of high-grade serous carcinoma can be associated with the BRCA1 gene mutation, somatic or germline. High-grade serous carcinoma with slit-like spaces, fusion of papillae. The luminal spaces are greatly narrowed by tumor cells creating slit-like spaces. Mitosis are conspicuous. High-grade serous carcinoma with micropapillary growth pattern. Micropapillary growth pattern is a less common architectural variant of high-grade serous carcinoma. It can resemble micropapillary type serous borderline tumor. High-grade papillary serous carcinoma with some mama bodies. The tumor cells are seen invading the stroma of this broad papillary structure. Samoma bodies are variable. Numerous samoma bodies are present in these two photos. Serous tumors containing numerous samoma bodies are generally well differentiated and have a better prognosis. That is low-grade serous carcinoma with samocarcinoma pattern. Serous adenocarcinoma of the ovary, acidic fluid sample. The malignant cells of serous carcinomas are often arranged in large, irregularly shaped three-dimensional clusters of crowded cells. Higher magnification reveals crowded large cells with round, dark nuclei, large nucleoli, and pale vacuolated cytoplasm. Mitosis are often present. Immunohistochemistry of ovarian high-grade serous carcinoma. Serous carcinoma shows a strong and diffuse nuclear staining for P53, the most common staining pattern in serous carcinomas, PAX8, WT1, in contrast to endometrial serous carcinoma, which is usually negative or only weakly positive, P16 nuclear and cytoplasmic positivity. It is important to note that apparent P53 expression that correlates with TP53 mutations. There are three patterns: overexpressions, strong diffuse nuclear staining in more than 80% of cells, missense mutation, null phenotype, complete absence of staining, loss of function mutation. Cytoplasmic expressions. Cytoplasmic P53 expression with intensity similar to that of internal nuclear controls. Loss of function mutation disrupting nuclear localization domain. Wild type normal immunoreactivity. These two photos show an ovarian serous carcinoma showing normal wild type pattern of P53 expression with a variable proportion of tumor cell nuclei staining with variable intensity. Wild type normal immunoreactivity means scattered, patchy, weak nuclear staining, mid-epithelial, basal sparing. Note: this wild type pattern should not be reported as positive because this is ambiguous reporting language. Serous carcinoma also shows positivity for CK, strong and diffuse membranous staining, negativity for CK20, positivity for HER2-neu oncoprotein, not complete strong membranous staining, variable nuclear staining for ER and PR, patchy cytoplasmic positivity for vimentin. Differential diagnosis of high-grade serous carcinoma. It includes high-grade endometrioid carcinoma, which features more elongated villus papillae, glands with more rounded luminal contours and preserved nuclear polarity, background of endometrioid features such as endometriosis, endometrioid adenofibroma, secretory or squamous morula metaplasia, diffuse nuclear positivity for ER and PR, patchy positivity for P16, negativity for WT1 in contrast to serous carcinomas. Clear cell carcinomas with solid growth are more difficult but in general display a less severe degree of nuclear atypia than high-grade serous carcinoma. Mitotic count rarely exceeds 12 mitosis per 10 high-power fields. Areas of more characteristic growth patterns, such as papillary and tubular architectural patterns, are usually present. Presence of hobnail cells and uniform atypical nuclei, more prominent hyalinized cores, positivity for napsin A diffuse expression, positivity for HNF1 beta, hepatocyte nuclear factor 1 beta, nuclear staining, normal P53 staining, negativity for ER, PR, and WT1. Prognosis and treatment of high-grade serous carcinoma. It is an especially aggressive tumor and the patients tended to have a poor prognosis due to high nuclear grade, that is nuclear grade 3, advanced stage of disease at presentation, that is stage 3 or 4 disease, extra ovarian spread in more than 95%. Frequent vascular space invasion, a widespread dissemination involving abdomen, lung, liver, pleura, and abdominal lymph nodes. Median 5-year survival rate range from 15 to 55%. Stage at presentation and amount of residual disease after debulking are the most important prognostic factors. Platinum-based chemotherapy is the first line of therapy, either after primary debulking or in the neoadjuvant setting. Low Ki-67 proliferation index is associated with platinum resistance and decreased survival. Primary surgical debulking and staging are preferred. PARP inhibitors are part of second-line systemic treatment for patients with BRCA1-2 mutations, either germline or somatic. Despite therapy, vast majority eventually die of the disease. Chemotherapy response score, CRS system. It was developed to assess and document response to neoadjuvant chemotherapy. It correlates with progression-free survival and response to first-line platinum therapy. The CRS has 3 categories. CRS score 1, no or minimal tumor response, mainly viable tumor, no or minimal regression-associated fibroinflammatory changes limited to a few foci, CRS score 2, appreciable tumor response with residual tumor, extensive multifocal or diffuse regression associated fibroinflammatory changes with multifocal residual tumor which is regularly distributed and easily identifiable. CRS score 3, complete or near complete response, mainly regression associated fibroinflammatory changes, absent or minimal tumor. These are the references. Thank you.